Hey future respiratory therapists, in this video we're breaking down intermittent positive pressure breathing, the things you need to know how to control the machine and the effects it has on your patients. Let's dive in. Okay, so here we're talking about IPPB, and I promise you this is the only video I ever do about IPPB, because myself, I see IPPB as being a respiratory therapy modality that is quickly disappearing, and as well it should. Let's give you some history. IPPB showed up and it was the latest and greatest thing, and in 1974 at the Sugarloaf Conference in Connecticut, USA, the AART conference said, wait a second, maybe IPPB isn't as great as we think it is. What we found out is that the hyperinflation that we consider to be happening with IPPB therapy is actually an overinflation of healthy alveoli, not necessarily a recruitment of atelectatic regions. And so that's what came out in 1974. Now, if I'm not mistaken, we're about 45 years out from that. And if I'm not mistaken again, if you work in a facility where there are IPPB machines still present, then you better hang on to the few functional ones you have, because there's no parts available for the rest of them. This machine is going away, okay? As great as it might have been thought to be, it's not there anymore. So we have to move on from IPPB. But I will also tell you that I see the value in IPPB being taught in the didactic material or in the classroom area of stuff for respiratory therapists and those studying to be respiratory therapists. I see IPPB being valuable in giving you a very early introduction into mechanical ventilation. Now, the first thing you need to know about IPPB is that it is considered a pressure cycled ventilator, because that's what it is. Now, when we talk about cycle, we're talking about the mechanism that ends inspiration and begins expiration. So when you talk about pressure cycled ventilator, you're telling me that when a preset pressure is reached, then the ventilator or the machine is going to allow the device to cycle in to exhalation. Now, the number one thing most students get mixed up on is that, oh, IPPB is just like pressure control, but it's not, okay? So we're gonna talk about IPPB, but before we get there, let's talk about the differences between IPPB and pressure control. The first thing you need to understand is that pressure cycled is associated with IPPB. A preset pressure is reached, and that cycles the machine into exhalation. Now, when we're talking about pressure control, you need to understand that pressure control is time cycled. It reaches a preset pressure and then holds for a set inspiratory time and then cycles into exhalation. That's the difference. Let me draw you a graph here so you get the illustration I'm talking about. IPPB looks like this. So this is IPPB. This is pressure control. Now, while there are similarities between IPPB and pressure control, they're not the same. For example, if you increase the pressure on an IPPB, it will result in a greater volume. That's true. If you increase the inspiratory pressure in pressure control, it will result in a greater volume. That's true as well. So those terms, they have similarities, but the differences falls here. IPPB, let's just say we have it set at a pressure of 25, is going to look like this. This is a pressure waveform. Both of these are pressure waveforms. Pressure rises, it reaches 25, and then it cycles in to exhalation. Okay? When it reaches the preset pressure of 25, it cycles in to exhalation. Now, pressure control ventilation looks like this. coming along here, if you're set at 25, then pressure rises to 25 and it holds for a set I time and then goes in to the expiratory phase. So this is different. This is pressure cycled. Pressure control is time cycled. Two different things. So do not think of an IPPB machine as a pressure controlled ventilator or the same as pressure control ventilation. They're two different things. Now, let's break down the IPPB machine for those of you who are learning it or about to learn it or have just learned it and you're learning how to work with it, okay? It's a very intimidating machine, first of all, because this is really probably the first device that you're working with where you're like, oh my gosh, I'm measuring tidal volume and I have all these buttons to push, but you really don't have that many buttons. Let me break it down. I'm going to get rid of this. And now we're just talking about just IPPB, okay? So in IPB, you have a pressure knob, you have a flow control, and you have a sensitivity control, okay? And here's how it works, okay? Pressure controls tidal volume. Flow helps to control I time. Sensitivity helps to control patient triggering of the breath, okay? And these are the questions that you might see on your MBRC exam. Now, why is this still on the MBRC exam? I have no idea. You can put a comment down below and ask me, and I'm going to tell you I have no idea, okay? But it's still in use, and that's probably why it's still on the exam, all right? Other than that, I don't know why. I'm not sure why they're completely not gone, but they are still relevant today and in many facilities across this country, right? So, if we know that pressure controls tidal volume, then what you need to know is that how do I get my tidal volume? Well, we know that clinical practice guidelines says that when you do an IPPB treatment, you are shooting for 10 to 15 mLs per kilogram of ideal body weight. So let's just say that our tidal volume should be 960. Okay? We know that that's what we're shooting for a particular patient. Okay? If we're looking for 960 as our minimum and we get back 710, then what you need to know is what do I change to fix my exhaled tidal volume? Am I doing this treatment correctly? The answer is no. If you're getting back 710 and we know that the minimum range for exhaled tidal volume is 960, then we need a larger volume. If we want a larger volume, we need to increase pressure. That will equal a larger tidal volume. Now let's say our tidal volume comes back at 1300 and our max tidal volume was 1050. Well, now we understand that we need to turn the pressure down. So to do that, we know that turning the pressure down will equal a smaller tidal volume. Okay? So if you ever have a question on either a class exam or an MBRC exam that asks about exhaled tidal volume in regards to IPPB, if you want to increase it or decrease it, then the pressure is what you're going to do. You're going to adjust your pressure. More pressure equals more volume. Less pressure equals less volume. That's where we stand. Now when it comes to flow, we have two areas that we need to address. If you were giving an IPPB treatment and the inspiratory time seems insanely long, like, wow, this is a really long inspiratory time, right? Then you need to give that breath faster. You will do so by increasing flow. Increasing flow equals a shorter I time. And that's where it comes. Now, most of the time, these questions revolve around a very short inspiratory time. So you're given an IPPB treatment, and the inspiratory time is observed to be very, very short, rapid, and insufficient. Okay? But the patient is doing the therapy the correct way. Well, in that case, we need to decrease the flow, and that will increase I time. Flow related to I time. And this is where these two things right here, actually all three of these, but as you can see right now, you can see how this relates to the physiology of mechanical ventilation. It all ties in together when you start talking about volume control. If you increase flow, you decrease I time. Volume control, you decrease flow, you increase I time. Pressure control, you increase pressure, you'll increase tidal volume. So you can see how this plays into the role of mechanical ventilation, which is why I still find it valuable to teach and to understand from an early respiratory therapy student perspective. Okay? So now when we talk about sensitivity, we're talking about the patient's ability to trigger the vent. Okay? Now these are in negative numbers. Okay? So ideally you want it around -2. I'm going to draw a line over here, and I'm going to put -2 here, 0 here, and we're going to go forward. Okay? And I'm going to help make this make sense. Okay? If you have a patient who is trying to trigger the vent, but the vent will not cycle on. So when you're looking at the pressure manometer on the IPPB machine and you see a large negative swing, but the vent fails to cycle into inspiration, then it means that your sensitivity is set too strong. The patient is unable to initiate the breath. Okay? So you need to make the ventilator, the IPPB, you need to make it more sensitive. Now in this case, if we're going to make it more sensitive, we're going to increase sensitivity. So if we increase it, it means it makes it easier to trigger. Okay? Increasing sensitivity makes it easier to trigger. If you go from -6 to -2, you have increased your sensitivity. Now, if you want to decrease it, you're going the opposite way. If we're decreasing numbers here, then we're going the opposite way. You wouldn't want to ever decrease sensitivity unless you have auto-triggering happening, which means the IPPB machine is cycling into inspiration despite a patient effort. The vent should not, the IPPB machine should not cycle into inspiration unless the patient is generating a negative force on the machine. So if it is auto-triggering, then you need to decrease sensitivity to reduce auto-triggering. Okay, I know I'm running out of room right there, but that says decrease auto-triggering. You will decrease the sensitivity. You will make it less sensitive so that it doesn't trigger into inspiration on its own. Okay? Now that's the keys in understanding what to control. It's very simple, guys. If the patient is doing things correctly, okay, and we're going to talk about potential problems here in just a second. But if the patient is doing things correctly, then pressure controls tidal volume, flow controls I time, and sensitivity controls patient trigger. Now let's talk about some common problems that might happen with IPPB. Get rid of this. And we have premature cycling, okay? So premature cycling, this means the ventilator enters into exhalation prematurely. The number one cause of this, number one equals the patient is putting their tongue into the mouthpiece. That will reach the pressure prematurely and will cause it to cycle off. Number two is the patient is exhaling into the ventilator prior to the completion of inhalation. So if your ventilator, if your IPPB machine, and they call these a pressure cycled ventilator, is prematurely cycling in exhalation, then you need to ask yourself, is my patient have their tongue in the mouthpiece, or are they exhaling into the machine? And both of these lead to re-instruction for the patient. You need to re-instruct the patient on how to do the therapy correctly, okay? Now, another problem that comes up is barotrauma. You need to understand that anytime you give a patient positive pressure therapies, that this can result in barotrauma. So if you're ever asked a question about a patient doing an IPPB machine or an IPPB treatment, and they suddenly complain of a sharp, sudden pain in their chest, followed by tachypnea, tachycardia, and central cyanosis, then this has probably led to a tension pneumo. You need to stop the therapy and assess the patient for a possible pneumothorax, okay? You need to get a chest x-ray. If it's a tension pneumo, you need to consider needle decompression, assess for tracheal deviation, assess breath sounds, all of those things, okay? But you need to stop the therapy. Don't let a patient who's complaining of discomfort or sudden chest pain continue to do the IPPB therapy, because the longer you do it, the more air you push into this tension pneumothorax, and that's going to become a big problem for you quicker than if you would have stopped it earlier, okay? Now, the last thing we're going to talk about is hyperventilation. Now, hyperventilation is common with IPPB. Now, the reason these patients experience signs and symptoms of hyperventilation, which they will express to you by saying, I feel lightheaded, I feel tingling in my arms and my fingers, okay? Those are common signs of hyperventilation. Now, the reason they're hyperventilating is because we've taken them from a state of normal to increasing their tidal volume substantially. And breath after breath after breath of this leads to a reduction of carbon dioxide, a rapid reduction of carbon dioxide, which puts them with a low CO2 and a high pH, and that creates this sense of lightheadedness and tingling in their fingers. Now, what you need to do is to stop the therapy, give the patient a break, and observe. Explain to them why this is happening, and observe your patient to make sure that no further complications are happening. Okay? That's the IPPB breakdown. Why would we do it? In terms of non-responsive atelectasis to IS therapy or deep breathing and coughing, to help remove secretions, and even to help aid the delivery of aerosolized medications. Those were the initial indications for IPPB, okay? What do we need to change? Pressure controls volume, flow controls inspiratory time, sensitivity controls the patient's ability to turn the machine on or trigger into inspiration. And then the things you need to be concerned about are premature cycling leads to possibly the tongue being in the mouthpiece or exhaling into the machine. Tension pneumothorax is a very popular question on your MBRC exam. Know when to recognize it. And hyperventilation, when the patient complains of tingling in their fingers or lightheadedness. Okay, again, IPPB 1974 Sugarloaf Conference. It's not effective. It only overinflates healthy alveoli, does not recruit or effectively recruit underventilated alveoli. and 45 years ago they said, we don't know if this is actually as good a therapy as what we thought it was. The newer positive airway pressure therapies, AccuPap, EasyPap, Metaneb, in my opinion, are much better at achieving those goals. Okay? And so we should probably consider those modes if you have the opportunity to. If you don't, then you have to go with IPPB. But remember the complications that come from it. Do not use it on a patient with an increased ICP. Watch for signs of barotrauma. Watch for signs of hyperventilation. And always monitor your patients during their therapies. Never leave a patient on positive pressure therapy by themselves. Okay? I hope this helps. For the questions that I received over IPPB, I hope it clarifies things and makes sense. And as always, please hit the subscribe button. Please leave me a comment, a like. I appreciate it. I will respond to you. And thanks for watching. Best wishes.